So let me introduce myself, and then Rich can introduce himself. I'm John Poyton, Chief Exec at Redthread. So Redthread is a youth work charity. And so I'm not coming in to talk as a QI expert with years of experience in quality improvement within the NHS. I come from the youth charity sector, but have been working with the NHS now for 19 years, looking at adolescent health inequity somewhat broadly. So, and Rich is our statutory fundraising manager and supported our programme in the Midlands with the Health Foundation over the last couple of years. You can wave, Rich. Great. So,
Hi, how you doing?
I'm going to talk for a few slides, and then we'll hopefully have time for discussions. So, as I said, Redthread is a youth work charity. I started our work 19 years ago in primary care, looking at broad issues for young people, recognising that actually the GP in the community was a great access point, pretty poor at supporting young people to access, but if you remove some of the hurdles and created a more equitable opportunity for young people to engage, then the most vulnerable, most complex young people in that community would engage. That then led 15 years ago to the local hospital that lots of my young people coming in and out of regularly as victims of violence. That happened to be King's College Hospital in southeast London, for those of you that know it. And we've been looking at how to continually improve, innovate and scale that work now over the last 15 years, recognising that there is a teachable moment for young people when they come into the emergency department in crisis, where they have the opportunity to voluntarily choose to engage and ask for help. And that's the nub, I suppose, of that teachable moment, that for young people, particularly high risk, high harm, vulnerable, complex needs young people, this is often one of the few opportunities within a universal access sort of system that they have the choice to reach out and ask for help. Education, even within the family dynamic, perhaps they don't get that. Yeah, just jump back very quickly, Rich. As has already been said, I suppose young people, I feel, really deserve that equity lens. And so it was really nice to have already referenced that in terms of young people need extra layers of support, particularly those who don't have support from perhaps the same family dynamic that some of us would expect to be normal. Thanks, Rich. Sometimes this goes without saying, but I think we often, particularly in creating sort of helping systems or ecosystems for the population, and I don't know what your area of interest is, but we'll focus on adolescents, you will see very much the tip of the iceberg. And I think thankfully research around adverse childhood experience and childhood trauma has come to the fore in the last decade or so, and really helped us to understand that what we often see is just that behavior. It's a tip of the iceberg. The adverse childhood experience and trauma is often hidden, and what we need to be able to do better as professionals is learn how to read that behavior as a language of communication and not write it off as just bad behavior and label the child, which is often what happens when systems and services are siloed and working in isolation, and the young person or the patient is only seen from certain different angles. Thanks, Rich. So what do we look to do there? The team around the child model has obviously been seen as best practice now for a number of decades. But what can happen for that young person is they then feel, if you place the young person in the middle of this diagram as the team around the child classic model, actually the young person can feel like they have a whole host of strangers around them who are to them asking exactly the same questions numerous times, and they're expected to organise their diary to go and have the same conversation numerous times throughout the week. If you look at an adolescent, in essence, they're then also expected, whilst dealing with pretty normal adolescent issues if we think within the health sphere, the way that the health system is siloed, they might be referred on to a substance misuse team for self-medicating for mental health, so they're also referred to CAMS. They might also be starting relationships, and they're referred on to sexual health teams. And so you're sending those vulnerable young people who actually are just dealing with the vulnerable transition of adolescence on 3 different buses to 3 different appointments to speak to 3 different adults who are going to ask them roughly the same questions. What we've seen over the last 15 years or more in working with these young people is that the teachable moment is about enabling the young person to talk about who is their trusted professional and how can we then wrap around, rather than creating further silos. And particularly when we see young people coming in who are stabbed or shot or raped, victims of violence in the emergency department, the best thing to do is sometimes not create an extra attachment bond, professional attachment bond, and insist that we're now going to add that young person to our caseload if that young person already has good epistemic trust with another professional in their network. Rich, do you want to jump on to the next slide? And are you going to take over from this one?
Yeah. So supporting those young people's, those high-risk young people, Redthread's YVIP provides those reachable moments to access high-quality, tailored support in a safe place in the hospital and the community. So these trauma-informed specialist youth workers are able to provide that tailored support. And where medical staff often have restricted time to support young people holistically, the youth workers are able to provide that important time. And as John alludes to, make sure that it's all joined up and that the network is around the individual. So on the left-hand side, the ambit model, that's the heart of what we do around scaffolding existing relationships, for example, and managing those young people's risk. An important part of what we do also is around training and development of both hospital staff, but also community personnel as well, to make sure that we're building their confidence, skills, and knowledge to support young victims of violence and exploitation in the best possible way. So we're on this journey of improvement, and we've got close collaborators with us. So for example, we've developed a clinical champions program where we've recruited hospital staff to support us to raise the profile of our program, but also help generate increased referrals. And we have a youth ambassadors program as well that listens to the service user, to the young person, the patient, to make sure that they are able to inform service delivery, but also help raise the profile of Redthread at events, and also with politicians and the like on the policy side to make sure that the youth violence agenda is being addressed properly. We have a number of evaluation projects, some ongoing and some due to start. So we've got an exciting one starting, funded through the National Institute for Health Research, through the Nuffield Trust on our UCLH site in London. We've pivoted successfully during lockdown. So initially, lockdown 1, working remotely, and that was a challenge for us, but we felt that we dealt with that effectively, working remotely, but had to use creative methods to support those young people virtually. And in lockdown 2, we've gone back into the hospitals in the summer, and we've continued that as key workers and working in close collaboration with the hospital staff. Innovation's at the heart of what we do. We've created specialist roles. So for example, young women's workers in London, there's an exploitation worker, a new role in Birmingham, for example, and we're trying to work in primary care to make sure that we're able to support young people upstream, sort of early prevention agenda. And we're looking to scale that impact effectively. So we're creating an evaluation framework that will help us scale effectively. And in order to scale, which we've done, we've had to grow the infrastructure, making sure that our head office is able to support the whole function and the frontline practitioners effectively. So in terms of outcomes, for last year, on average, 32 referrals per month per site, more in the major trauma centres than the district generals. We supported over 1,200 young people across the 7 sites that we had then. And we trained hundreds of hospital staff and community service personnel. We have a set of risk indicators. So for example, risk of harm from others. And on average, there was 92% average who maintained or had decreasing risk, which is positive. And in terms of reattendance from the Midlands evaluation that's been completed, those who we supported, there was a 60% reattendance rate reduction. which is very favourable. There's a cost benefit analysis that's been completed by external consultants, and that showed that for every £1 that we spend on the YVIP, there's £4.90 that was saved. And I encourage you to look at the Health Foundation video, which I can post a link, which shows the impact that we have on the young people, hospitals, and the wider system. Back to you, John.
So I think because this one started slightly late, it's time to go to questions. I think we've only probably got 5 minutes left. Really, for us, I'll finish on this slide. We are really keen, if we're recognising what the long-term plan talks about as the high harm, high risk, highly vulnerable and complex child who is at risk of entering the criminal justice system, but only gets a paragraph in the long-term plan in the criminal justice appendix. We currently have worked out and are proving that there is a real teachable moment at this high end of the risk spectrum. However, we need to look at how those teachable moments can act like ripples in the pond, and look at moving upstream to do more preventative work. So for us, our 10-year sort of strategy is very much focusing around about how can we scale those teachable moments across the health system to improve the health of the wider population. Thank you for listening. Very happy to take questions before some of us get booted out of the room.